I consider this an honor. I'm someone who is so grateful to all of the people in this room, and especially the patients, because I know you understand the other side, but truly because those of you who are in this field of oncology and thymic carcinoma and thymoma and are studying it, you're making a difference, and you're impacting me, and you have helped me be here today. But my story doesn't really start there. I'm going to take you on a little side trip. You ready for a side trip, everybody? So we're going to go back in time, and I want you to visualize or go back in your memory banks, probably late teens. You had just graduated from high school, which we call it in the States, or secondary school. And I want you to picture yourself post-graduation. You're now in your undergrad, your very beginning in higher education. And in your undergrad years, you're in your first day, your first semester. Okay, is everyone feeling it, seeing it, experiencing that moment? For me, it was a tremendous time for many reasons, which I'll disclose shortly. But what I want to know about you is, did you commute on campus like I did? That's my campus, University of Dayton. Or did you possibly commute from home? Or possibly online, or maybe a combination of all three. So you're back in that place, remembering your experience. And the real questions I have for you is, how did you feel? What was it like as a young person to be entering this new phase of life where you're starting all over? In fact, you're leaving your family behind, and you're now on your own, many of you. What was that like? Were you happy, excited, anxious, scared? Or maybe like me, I don't know if anyone's read this book by Glennon Doyle, Untamed. She uses a word called skited. I was scared and excited. It was a really amazing time in my life. So now here I am. That's funny to see myself up there. 61, presenting with thymoma. Yeah. And much of what this group just talked about, I could very well relate to, and it was very informative, and I appreciate those presentations. But that's not where my story started. Nope. It started much longer ago. It started in university, freshman year, my first year of my undergrad. That's why I took you back there, so that you could step into my shoes, one patient's story, and really understand the gravity and the impact of a cancer diagnosis. I was so young. I was just a child, is what I felt like, even though I had this new independence. So if you're there with me, you can kind of respect what that diagnosis must have meant. So back in the day, so I just went to my reunion for my undergraduate work 40 years ago. And I have to tell you, I went back and I stayed in the dorms. And they're much different than what you see up on the screen there. They have like a suite of rooms, their own private bathrooms, couches and lounges. I mean, I lived in this cinder block room with a roommate and a sink. It was not quite as glorious as it is today. And we had to, my roommate and myself, had to walk down a hallway to the communal bathrooms. Now, this picture here, not really as bad. Mine weren't as bad as that. We did have individual stalls, so there's a bit of privacy while you showered. But then you see the bathrooms on the left, or the sinks on the left. You'd get out of the shower, I, being super modest at the time, would cover up from head to toe, chin to toes with a robe, because I didn't want anyone to see anything, right? So I'd brush my teeth, make my way back to my room, and it was a different experience for me that freshman year. 1980, that's when I had my first diagnosis. I went home here in the States. We celebrate Thanksgiving. Many of you know you have the big turkey, family, and many schools have a break for their students. So I went home in Philadelphia, an 8-mile ride from Dayton, and it was a little different than the dorms. I had privacy again, which was so exciting. And it was clean, I should say. It was really clean. And across from me, that first night when I got out of the shower, there was a mirror. And I could see myself, I didn't have to be modest, there was no one there, from head to toe. And that's when I noticed something. There it was, on the left side of my neck, a tumor that extended from my ear to my shoulder. Never saw it that whole semester because of my modesty. Had no idea that it had been growing. Yeah. So we headed to the doctors, and we found out that it wasn't a good thing. So there are moments which mark your life, moments when you realize nothing will ever be the same, and time is divided into two parts, before this and after this. And that was true for me. Before this, so young, vibrant, never sick, nothing. And after this, a different story. So the trajectory of my life, the path that I was to lead, changed drastically. I didn't know it then, but I can look back now and see clearly that my life was going to be led with cancer. It's not easy being a cancer patient. I'm here because of my gratitude, but I'm also here so that you can relate and understand. And I want to ditto Aaron Mosley's, the relationship we have is so critical. The communication, the dialogue. Yes, it's so necessary. I've seen it as a gift of cancer, as much as it was devastating. I've had the gift of cancer every decade since I was in my teens. And this gift, you're like, yeah, right, gift? Yes, gift. Because for me, I found my purpose. I've had different purposes throughout my life, but this one is quintessential in that now I know it's time to give back. And I've found that purpose. And some of you might know Viktor Frankl. He says, happiness cannot be pursued, it must ensue. Life is never made unbearable by circumstances, but only by lack of meaning and purpose. And you all do such amazing work and have a really significant purpose. And now I do too, at age 61. So, backtracking a little bit, the first, as I approached my 20s, was Hodgkin lymphoma. And at the time, we were talking about radiation in the patient gathering over here. I had what they know, mantle radiation. I was blasted. Now, back then, in the 80s, it was one of the first curable diseases. So this radiation, it cured me, but it had its consequences. And so following the Hodgkin's, radiation, I had surgery, laparotomy, spleen removed, lymph nodes removed. I did say radiation, yeah. It was really tough. I had to go home. I went to school at Villanova instead. I transferred, lost my hair, had burns all over my body. It was a little scary as a young person. In my 30s, it was my thyroid. a lump. The same surgeon who worked on me at 18 said, get rid of it. We took it out. I moved on, though. So this was in my 30s, the beginning of my career. And then in my 40s, it was breast cancer. Again, same surgeon. He said, let's get rid of it. So we had surgery. And then in my 50s, this is where pleural disease fits in. Well, actually, this is pre-pleural disease. This was thymic carcinoma. And the thymic carcinoma obliterated my superior vena cava. And I presented with chest pressure, went to the emergency room. They found it. I was whisked away into the ICU. And then from there, I would tell you that the 50s, with children at home, now I'm an empty nester, but it was more or almost as difficult as the Hodgkin's disease in my 20s. Up here is where I was impacted. Now, I present with thymoma, and this is the pleural disease that these beautiful people have been talking about. So, thymoma, yeah, I have it in my left lung, and I want you all to know that I feel great. I was lucky enough to find an amazing doctor. My husband is a big researcher, and he found NIH, and Dr. Rajan was my doctor for a clinical trial. Now, for my thymic carcinoma, I was at Penn, and there I received proton therapy and radiation. And I had no evidence of disease for 2 years. So that was pretty significant. 2019 is when it came back in the form of thymoma, and it's in the pleura of my left lung. So Dr. Rajan and his clinical trial and his team, Meredith and Suzanne and who else? Shannon, they were all there, and it was avelumab, immunotherapy. My doctor at Penn was a little bit nervous, Penn Medicine in Philadelphia, University of Pennsylvania. He really was nervous about immunotherapy because he thought that it could be devastating and might be life-threatening. But when he found out that Dr. Rajan had this study and it was a clinical trial, he was all about it. Go for it. And I will tell you that for 2 years, I worked with Dr. Rajan, and we were able to keep the cancer stable. But we started out every 2 weeks, then a month, then every 3 months. And at that 3-month part, I started having all the symptoms and the pain again. It came back full force. And I've never gotten better health care than at NIH. I went through a barrage of tests to figure out, okay, what's this about? What's going on? They were looking at my right lung, my left lung, and I was suffering, though. I was in a lot of pain. So Dr. Rajan made the decision to go to standard care. He started me off with pemetrexed. And I've never seen Dr. Rajan smile bigger than that first scan because it had shrunk so significantly. It was like a miracle to me because I didn't think that could happen. Now, I don't know a lot about it. You have to ask Dr. Rajan. The one thing I do know is that sometimes in patients, when they have the immunotherapy and then follow with the chemotherapy, there are better results. And so that's what I was experiencing. And I went back to University of Pennsylvania because at NIH, they only do clinical trials and research. So I had to say goodbye to my team there, who I'd bonded with, and my doctor back at Penn Medicine picked up where Dr. Rajan left off. And I've been with them for probably a little under a year. Bottom line, all this said, the one thing I want to tell you, and I kind of started out with this, is that I'm grateful. I'm grateful that you're doing this work. I'm grateful that there is ITMIG. I'm grateful for a rare disease that you are all focused on this. And I want you to continue the path because we need you. And I've seen how in the past, mantle radiation to proton therapy, it just keeps evolving. Keep going. It's awesome. You are doing great work, and it's appreciated. I have one hope, and that hope is that maybe the next time you see a patient, you maybe understand a little bit more, and you actually keep going and are motivated and excited about helping us continuing to live. Part of my story is my purpose is now I've written a book, Unraveling Fate, and this book is, because I've unraveled my fate, so this book is out there now, and you can see a video about me on unravelingfate.com, but it takes patients through the journey, their caregivers, friends, family, and my lessons learned psychologically how I dealt. As an 18-year-old, I was naive. In my 60s, I got it going on. I happened to be a meditation instructor and also a yoga instructor, and that's what's kept me together up here. So there's the physical we rely on for you, and there's also the mental that I hope that you consider each time you face a new patient, because it's not easy being a cancer patient. Thank you so much.
That was fantastic. Thank you. So we have time for some questions. Also thinking we're going to have chair prerogative, skip the break, move to the next session after the questions, and then that'll give us time to gather at the 6 o'clock meeting. So we want to have all the speakers from this session up, and we'll have a little time for questions, and then we can move to the oral abstract session.
All right, Chris Nabel from MGH. Marian, thank you for sharing your story, and it's very heartwarming to hear about the great response that you're having currently. So I hope you keep it up, or rather that pemetrexed keeps it up for you. Dr. Girard, I wanted to ask you, we heard about radiation and intraoperative chemotherapy approaches to controlling micrometastatic disease within the pleural space, and I'm curious if you can address kind of what we know about, for systemic therapies, how to control that microscopic disease for patients with stage 4A disease.
Well, thank you for the question. The evolution of the indication of high tox, actually, we moved from a situation where when we did a lot of induction systemic chemotherapy, such as 3 cycles of CAP, and then the high tox, and the pleurectomy plus high tox. And now we are more and more doing high tox up front without systemic therapy. The aim of systemic therapy in ITMIG tumors is actually to reduce the tumor burden to achieve R0 resection at the end, especially in thymomas. For thymomas, I believe that induction chemotherapy, preoperative chemotherapy, is not that much per se leading to a better outcome. No, what leads to a better outcome is the R0 resection, and chemo is helping to do that. It's a very different situation than lung cancer, where you are with induction chemotherapy trying to kill the micrometastasis and so on. Here, it's just a matter of achieving R0 resection. So this is why I believe that when you have pleural disease, you can do high tox, pleurectomy plus high tox, or some kind of reductive surgery plus high tox up front without a systemic therapy. And it is also a matter of safety and tolerability of the whole sequencing. And I believe that if you do systemic chemotherapy before surgery and high tox, the risk of adverse events is probably higher.
Thank you.
Andrew?
Thank you. Several of you mentioned observation and the fact that patients who develop pleural disease after their initial thymoma was managed are a somewhat different group of patients than patients who present with stage 4 pleural disease. We have a lot of patients in our practice with very indolent, multifocal, slowly progressing pleural disease. What do the panelists do with those patients? Thymoma, multifocal, slow.
Yeah, I should have mentioned that, but yeah, follow up for the small lesions. If you do not have a huge tumor burden, well, it's always difficult to say, okay, I will give you cap chemotherapy and so on. So you may even not be able to assess the efficacy at the end. So you need to wait in some patients and explain the patients that at some point there will be some treatment, but it's too small. So yeah.
Is that the approach in the other centers as well?
Just it's for thymoma. For thymic
Yes,
carcinoma,
thymoma.
probably the situation is a little bit different because the growth curve is probably higher.
I think with a lot of the patients, it's a discussion with the patient. I think that for many people, you know, understanding that if it does come back in a way that's quite extensive, I know we've heard some amazing stories, but I think for many people, once it's in that setting, we're not going to be able to cure. And so the focus is on how do we help people live as long as possible, feeling as well as possible. And sometimes from that perspective, the delay gives people that really good quality of life, and then come in with the systemic treatment that can shrink or the radiation. But it depends on that pace of growth and obviously that patient's perspective. And for some people, that's just not a way that they want to live. That idea that it's there and growing impacts everything else that they're doing. And so for them, then sometimes a bit more aggressive earlier, but it's that balance.
Yeah, I mean, I would agree. And, I think observation as a treatment isn't something that we talk enough about in this situation. And there are we have plenty of patients that we are doing that with, and at some point maybe, further intervention has diminishing returns, especially as it may impair quality of life. And a lot of times if you have, limited burden of disease and they're otherwise asymptomatic, they're probably worse off getting additional treatment in those settings because you're not really changing the natural history of the course at that point. So, I mean, I think observation is something to be discussed and considered, but it depends on the patient, it depends on the situation, it depends on the pace of progression or, how fast or slow it is. But I think that's certainly a viable option.
Others down the panel? Anybody else?
I completely agree, yeah.
I'm Stephanie Peters. I'm a radiation oncologist from Maastricht in the Netherlands, and I have two questions. My first question is for Dr. Shepard about the hemothoracic radiotherapy. What did you consider taking into account the fissures of the lung, because there's also some pleural space there? How do you deal with that?
Yeah, so in the protocol, we didn't exclude disease in the fissures because it depends on exactly where it is, how big it is, how close to the periphery it is. So if the fissural disease is close to the periphery, with protons we can potentially get an acceptable plan. So we didn't exclude that in the protocol. However, if there's bulky disease in the fissures, we'll likely have a difficulty achieving an acceptable plan, and so then they wouldn't qualify.
So you only take it into account when there is visible
Correct.
disease
Yeah, we don't
in the
electively treat in the fissures.
Yeah.
Right.
Okay.
Even though they're at risk for sure.
Yeah.
Yeah.
My second question is about MRI for pleural disease, because it's always a bit tricky. Well, no, what is the role of MRI in the diagnosis of pleural disease? And maybe it's a question for Dr. Kurlemans, because he said they always do a MRI before surgery. And what's the additional value? Because you inspect the whole pleura, I think, when you operate. So is there anything, does that sometimes change your treatment?
So I adopted the use of MRI from our mesothelioma experience, where you really want to assess how deep the disease is going into the chest wall and to see if you can resect all of it, especially in cases where you have a pleural recurrence and you already had some partial pleurectomy before. It helps to assess the operability of the lesions. And while doing this parietal pleurectomy, you sometimes have difficulties in assessing if you can resect all tumor at the parietal pleura, and then if you can assess an MRI up front and see if it is tumor or more fibrosis or anything else that helps, because the frozen sections during operation don't really help you to guide through the operation if you will be able to attain R0 resection. That's one. Secondly, the MRI also helps in really assessing the operability regarding the mediastinum, and most especially in the first patient I showed you with the caval vein and also the right atrium to see if there's ingote or not. And this morning we saw some very nice pictures of functional MRI to assess if there's ingote in the myocardium or not. So I had to learn to assess these MRIs. It's not so easy because you have so many images and you really have to, but after a few years now you try to understand T2 weighted, and the more you see it, the better you appreciate it, and it helps me to guide towards R0 resection.
So if I understand well, it's not to detect all the small lesions, but more for the larger lesions to see how they invade the...
Definitely.
Okay, thank you very much.
Thank you. First of all, I'd like to say I'm so grateful that the ITMIG organization exists. It's been a great comfort to me as a patient with thymic carcinoma to be able to Google and discover that there's actually an organization somewhere in the world who takes the process of coming and discovering how we might be able to deal with this disease professionally. And so I'm a very keen supporter of you in my first appearance. You'll probably see me hopefully in many years to come. The second thing was just to, if I can say that, just to the panel by way of advice, I wanted to hear every word you've had to say tonight, and I actually have struggled to hear it, either by a combination of the fact that you're not speaking closely enough to the speaker, and if you could move your speakers a little, your amplifiers a little closer to your mouth, so we might be able to hear, and a combination, obviously, of the foreign languages. The combination of both means that I feel I've missed some of the words of wisdom, so if we could please make your responses a little closer. The process I've gone down very quickly is just to have a full resection and not to have chemo or general radiation. And Anne-Marie, I've followed down the stereostatic radiation side of things for 5 nodules, which only completed 2 days ago. So I guess it's a statement about how you can recover from that quickly, that I'm over here that quickly. But is it a legitimate, appreciating that I'm not one of your young candidates, but I'm probably just as fit. Is it a legitimate process just to contemplate stereotatic treatment of occasional pleural nodules as a long-term, long-term or not?
So you mean, can we continue to do SBRT for pleural nodules like long-term?
Yeah.
Yeah.
Decades.
I mean that's
Decades.
often one of our approaches, just to continue to observe when the pleural nodules get to a point that we feel like they would benefit from treatment. Then if it's not an ideal lesion for surgery, then we'll absolutely consider doing more SBRT. Yep. I mean, it gets to the point where with each additional course of SBRT, you have to see what your lung function is like, and how we think, based on the size of the lesion, the prior lung dose you previously received, whether or not we think it's safe for you, because for each additional course, there's an increased risk for pneumonitis. But depending on the situation, we can continue that.
I mean, is one of the alternative answers the imprint? I think it was you were talking about. And then you said there was better for a young person, and there was 2 or 3 months of recovery. Pneumonia, I guess that was actually pneumonia, right. Stage 2, stage 3 pneumonia. But also the fibrosis that came up. Yeah. Is that likely to be the side effect profile of imprint? Yeah,
for imprint, I would say there's definitely the risk that the periphery of the lung can develop some fibrosis, and that area of the lung is less functional lung. So that's a risk with the treatment. How much that clinically impacts a patient is variable. And on the trial, we're getting pulmonary function tests before and at defined points after imprint, so we can really truly better assess how the imprint affects lung function.
Okay, and you're doing a trial at the moment on
Yeah,
imprint at the moment?
correct,
Okay.
right.
Well, I'll be very interested to see the results.
Yeah.
Once again, thank you very much for what you're doing for this cancer.
Frank. We've heard from a number of patients today. Appreciate your story. I think they're inspiring. We've heard a lot about how important the collaboration and the relationship is, and listening and talking together. It motivates me to talk a little bit from my perspective about the birth of ITMIG, I guess I would say, and the value of the collaboration. So, ITMIG started because there was a patient and family organization, the Foundation for Thymic Cancer Research, that had really kind of established some things, but said, we want to bring more science behind this disease, and we need to have an organization that is going to do that. And that really led to ITMIG. That really led to saying we need to somehow figure out how we can bring the researchers and physicians together to develop an infrastructure to be able to collaborate, to try to put more science behind things, to establish some guidelines, establish some standards, establish an infrastructure that allows us to do things. What I want to point out, though, is that the collaboration, I think, between the patient side of that and the physician researcher side was so critical. And early on, there were many things that we said, well, we really should establish a database. We really should establish a staging system. We really should establish, better understanding of, the WHO classification. We're not doing that very well. We need to do this better. But to do this, it's going to require some infrastructure that we have no idea how we're going to be able to do that, And it was really the patient side of it that said, you just figure out what you need to do. We'll cover your back. We'll figure out how to cover that back. You figure out what you need to do. And that sort of motivation from that side, if we didn't have that, we would not have had the guts to try to create the infrastructure that we created with ITMIG. That piece of it is so important. And so I want to just go back to another thing. The other part of ITMIG has been that we have kind of looked for people that would be willing to get engaged, be willing to tackle certain things, and there were various committees, various ideas that took off immediately. There were some that kind of floundered and didn't really find the right person, and we kind of kept going around and tapping people on the shoulder and saying, hey, what do you think? This is something that we need to try to tackle. Do you think you could take this on? And over time, we just sort of found the right people that had a skill set that, moved things forward. I think the same was really true on the patient side. There were people and family members that had a particular skill set, either with fundraising or with creating awareness. The May, Thymic Awareness Month, that's an example. Another thing that can help us move forward. It's all sorts of different things, but particular people that had a particular skill set that then said, okay, let me use that. Let me try to do something. And I'm kind of making, I'm trying to tell my sort of story, I guess, of my journey in this. But that collaboration is so critical, and I think we all have to kind of keep doing that. Keep finding particular people that have a particular skill set, are willing to get engaged, and then figure out how, working together, we can really move things forward, because we have done a lot, but there's no question we have a lot more that we need to do. But we need to figure out who has the skill set and who's willing to be engaged, and we need that piece from the patient side very much, because there are things that we can do, but that things that we can't do very well on the patient side, and vice versa. You know, we need to keep working together.
I just want to recognize that Frank is really sort of the father of ITMIG here, and the champion who really sort of brought everyone together, a lot of disparate groups and sort of disorganized clinicians that we are, and brought us in a sort of unified group. So it's a thanks in large part to Frank that we're all here today. So I just want to give Frank a round of applause. One more question, maybe? Oh, sorry.
I was just going to say, if I could add, the folks from Italy, you are doing an amazing job on the patient side. Laura Abate now is running, and I know one person did mention it, a patient group online internationally, and it's fabulous. And there are many people from Britain, Belgium, Italy. I'm the only one from the States, so I don't know about that. So those of you from the States, come on in.
Yes, exactly. One point was this, because I'm from Italy, and so I was just advertising that we have a similar group, and I'm very glad that you are part of with Laura, and this is a very good initiative. So I greatly appreciate your story, and I think that we as physicians, we need these contributions in the same way that we need to know the latest results, the latest clinical trials. So sometimes, and I think this is extremely important for us. And so congratulations for your contribution. It was really inspiring to me. Two very quick questions. For a pleural disease, to the surgeons, of course. Again, the same question that I put this morning. Would you behave differently for the pleural disease in case of thymoma or thymic carcinoma? Because the results are much worse for surgery in thymic carcinoma, first. And second, I fully agree that pleural disease is in most cases a local disease. It's not something like the mesothelioma. So what's the reason to do an extended pleural decortication in case of different discrete implants? Wouldn't it be better maybe just to resect the implant and not take out all the visceral and the parietal pleura, just because this, I agree, is a local disease, it's not, let's say, an extensive disease?
I guess I could start.
Yes.
You guys can finish. I guess my opinion on thymic carcinoma, it's a different disease. I think you shy away, Enrico, as you probably do, from dealing surgically with pleural disease in thymic carcinoma. With respect to the surgical technique, I'm kind of intrigued with your approach to doing this radical pleurectomy. I think if you look at the data, though, any pleural metastatectomy patients, the series I showed, 70 to 80% of those patients recur, and that's our experience too. Within really 2, 3, 4, 5 years. So, you know, I was inspired by Erin's, the previous patient. You know, she's gone through 12 operations, and she's endured a tremendous amount. I think that's unfortunately the rule rather than the exception in these types of cases. And I'm not, I don't want to second guess by any stretch of imagination. She's alive and doing well, and obviously we're all happy about that. But I think the trend is probably going to be to do less surgery and more systemic, more radiation with these. I think even with my personal opinion, even with a radical pleurectomy, and again, I'm kind of impressed with what you're doing there, and maybe adding the heated chemotherapy on top of that will have some additional benefits. But, and I think you ought to keep studying that, obviously, and hopefully it'll prove beneficial. But I think that, you know, this is going to come back. Even if you do an extrapleural pneumonectomy, if you look at the series, a third of those patients recur. So it's almost impossible to eradicate this, and most of these are going to be chronic diseases. And we're going to rely on radiation down the road. I guess the good news is, we talked about observation here. The patients that relapse with pleural disease tend to behave more benign than the patients with de novo pleural disease. So I think that puts an argument in favor of observing some of these patients too.
So thank you, Enrico, for the very important question to which, of course, I don't have the answer. Regarding thymic carcinoma, I agree with what you write in your review. I would not treat it the same way, unless maybe in a very fit young patient who wants everything done, then maybe yes. Regarding the number of nodules, I think there we really need to come to consensus. I think when you have 3-4 isolated nodules with a de novo thymectomy and you do a partial pleurectomy of these nodules, that would be okay, and then you can follow up. Once you have more, probably, you will miss some micronodules because you can be guaranteed that there will be micronodules which you can't visualize at that moment. And so although you might reach a macroscopic R0 resection, not a microscopic one. And I think what we learned from the ESTS data is that it is really crucial, first, to attain an R0 resection, because that will result in better results. Secondly, the more nodules, the worse the outcome. And this is an independent risk factor for the outcome on the long term. I think another reason is that if you do multiple pleurectomies time over time, every time it becomes more difficult, and it becomes also more difficult to have a complete pleurectomy decortication at a certain level. Because of all the fibrosis, the technique just becomes more difficult, and you will not be sure that you will attain an R0 resection. So I think you can do it once, maybe twice, but then I would go for the complete resection. The HITOC, maybe there is some data. It's not really overwhelming yet, but I believe in it. And what we show now is that it's feasible, it's safe, and then I question myself, why not do it? Because there will be a benefit. On the long term, we don't know yet, but there might be a benefit. But I think, Dr. Gerard, maybe we should come to some kind of consensus group to discuss about these approaches for limited versus multiple pleural droplets. Were there any initiatives that will be taken?
I believe this is in the scope of ITMIG. I mean to have all the people doing such approaches come together and discuss some recommendation or consensual guidelines on this topic, for sure. Yes.
Excellent panel and talk this evening. I'm a clinical oncologist from UK. For Dr. Shepherd, I'm very interested in the dose pain that you shared, but using proton therapy, I guess, because proton treatment is not available universally. 2 places in UK, our patients cannot reach these places. So for those centers who would like to treat, other than proton therapy, the external beam, IMRT, is it a standard? Because when I approach my physics team, say it's not, we are not trained, we don't do it, it's only in trials. But there are quite a few patients that, who would benefit with the local radiotherapy. Would you recommend it as standard? And what would be the organs at risk, the DVH for those? Would you be able to share?
So,
that would be very useful.
Sure. So we can also do it with IMRT. It was actually established at MSK with IMRT. And the paper, the JCO paper, all those patients were treated with IMRT. So it's possible to do it with IMRT. You can get, in general, you can get acceptable plans. It's a little easier to get acceptable plans with protons. So that's why if logistics allow a patient to get protons, we tend to prefer it. But that doesn't mean that they can't get it with IMRT. So that's still feasible. And then what was your other question? I forgot.
See the dose volume histogram.
Oh,
for
yeah,
the
so-
lung-
so
for the
right,
IMR
so,
compared to the proton.
For thymic patients, I think it's important to just do it on trial, though, because we really don't know like the impact on the toxicity and the long-term toxicity. So I would say, you know, it should probably be on trial. And the technique is very sophisticated, and it does require experience from the physics staff and dosimetry staff to be able to do that technique, because it's pretty specialized. But you know, our protocol tries to detail that as much as possible. Yeah.
Great.